Mrs. Halverson, 66, diabetic, 2 weeks post above knee amputation. She rates her pain at 9 out of 10. The pain is in her right foot. Her right foot is in a hazardous waste bin in the hospital basement. She asks me, quietly, why it feels as if someone is crushing toes she no longer has. I have no answer that satisfies either of us. I have been a physician for 19 years. This is one of the cases I cannot fully explain. Mrs. Halverson is not unusual. She is typical. Depending on the cohort, between 50 and 80% of amputees experience phantom limb pain within the first 6 months after surgery. The figure has been stable for over 2 centuries. In 1871, the American Civil War surgeon Silas Weir Mitchell, working at Turner's Lane Hospital in Philadelphia, published detailed accounts of Union soldiers who described vivid, often agonizing sensations in limbs that had been shattered by Minié balls and sawed off on field tables. He coined the term phantom limb. His descriptions, read today, are clinically identical to what I hear on rounds. The character of the pain is heterogeneous. Patients use the words burning, cramping, shooting, stabbing, electric, crushing. Some describe the phantom hand as clenched so tightly that fingernails dig into a palm that does not exist. Others describe the missing foot as twisted into an impossible position they cannot release. These are not metaphors. On questioning, patients will localize the pain with anatomical precision, pointing to the space where a knuckle or an arch used to be. It is critical, clinically, to distinguish this from residual limb pain, sometimes called stump pain. Residual limb pain arises from the tissue that remains, often from a neuroma, infection, or poorly fitted prosthesis. Phantom pain is referred to tissue that is gone. The two can coexist, and frequently do, but they are separate phenomena with separate management pathways. The literature on prevalence is consistent. A large prospective study by Ephraim and colleagues, published in the Archives of Physical Medicine and Rehabilitation in 2005, surveyed over 900 amputees and found that 79% reported phantom pain. A more recent review in the Lancet Neurology by Floor, Nicolaisen, and Jensen in 2006, and subsequent work from Herta Floor's group at the Central Institute of Mental Health in Mannheim, confirmed those numbers across European and North American populations. In other words, this is not rare, not fringe, not a curiosity. It is the majority experience after major amputation. A teaching hospital of any size is managing dozens of these patients at any given moment. What makes the phenomenon difficult is not its prevalence. It is that the pain is real, measurable on validated scales, often disabling, and directed at anatomy that is demonstrably absent. The nociceptors, the peripheral pain receptors that ordinarily generate such signals, have been surgically removed and incinerated. Something else is generating the signal. The question of what and from where is older than modern neurology and not yet fully answered. The mainstream neurological account of phantom pain is, in its broad strokes, well established and largely correct. It has 2 levels. Peripherally, when a nerve is transected during amputation, the severed axons do not simply die back quietly. They attempt to regenerate, and in the absence of their former targets, they form neuromas, disorganized tangles of nerve endings that fire spontaneously and ectopically. These aberrant signals travel up the sciatic or brachial trunks into the dorsal horn of the spinal cord. This is demonstrable. You can infiltrate a neuroma with local anesthetic and, in some patients, abolish the phantom pain temporarily. Centrally, 2 mechanisms dominate the literature. The first is spinal central sensitization. After the loss of normal afferent input, neurons in the dorsal horn become hyperexcitable, amplifying whatever ectopic signal arrives. The second, more famous mechanism is cortical reorganization. The somatosensory cortex, mapped by Wilder Penfield in the 1930s as the so-called homunculus, contains a topographic representation of the body. When a hand is amputated, the cortical territory that represented that hand is deferented. It does not remain silent. Adjacent territories, particularly the face representation, expand into the vacated area. Herta Floor's group demonstrated this with magnetoencephalography in a 1995 paper in Nature and showed a strong positive correlation between the magnitude of cortical reorganization and the intensity of reported phantom pain. The skeptical position within this consensus is articulate and should be taken seriously. Tamar Macken, now at Cambridge, has published a series of functional MRI studies, including work in eLife in 2016, arguing the older model may be inverted. Her data suggests that patients with preserved, not diminished, cortical representation of the missing hand often report more phantom sensation, and that the simple story of maladaptive plasticity is incomplete. Anil Seth, the consciousness researcher at Sussex, frames phantom pain within a predictive processing account. The brain generates a model of the body, and pain is what happens when the predicted limb and the sensory evidence fail to reconcile. Under this view, the pain is not coming from anywhere. It is being constructed, top down, by a brain that has not updated its body schema. The neurochemistry, to the extent we understand it, involves NMDA receptor-mediated excitatory transmission in the dorsal horn, GABAergic disinhibition at multiple levels, and altered opioid signaling within the thalamus and anterior cingulate cortex. This is why gabapentin, pregabalin, tricyclic antidepressants, and each have a plausible pharmacological rationale. None of them work reliably, modest effects, significant side effects, and a substantial fraction of patients for whom nothing in the pharmacy touches the pain at all. This is the consensus I was trained in. It is defensible. It explains a great deal. It does not explain everything. There are cases in the literature, and in my own practice, that the consensus does not comfortably accommodate. The first is the patient with bilateral thigh amputations, described in a case series from the rehabilitation literature, who had failed gabapentin, pregabalin, tricyclics, opioids, and a spinal cord stimulator. His pain was bilateral, burning, and he slept in 20-minute intervals. His clinicians, having exhausted the pharmacological algorithm, fitted him with a single prosthesis on one side and positioned a mirror so that the prosthetic leg appeared, in reflection, to occupy the space where his other leg had been. He watched the reflected limb move as he attempted to move the absent one. Over a graded protocol, his pain intensity fell by more than 85%. The frequency of his pain attacks fell by more than 90%. No drug entered his system. The intervention was a mirror. The second case, published by Stankovic in 2018, is Mrs. Halverson's near twin. A 66-year-old woman, diabetic, above-knee amputation, initial pain 9 out of 10, refractory to analgesics, with depressive features. 3 weeks of 20-minute daily session of mirror therapy reduced her pain to 1 out of 10. This is the case I returned to when my own Mrs. Halverson asked me what we can try next. Because the answer, increasingly, is not another molecule. It is a piece of household glass positioned in a particular geometric relationship to her body. The technique itself was formalized in 1996 by V.S. Ramamuchandran at UC San Diego, originally published with Rogers Ramamuchandran in Proceedings of the Royal Society B. The patient places the intact limb on one side of a parasagittal mirror and the residual limb behind it. Looking into the mirror, they see what appears to be 2 intact limbs. They are asked to move both. The brain, receiving congruent visual feedback of a limb it believed lost, does something the pharmacology cannot reliably do. It stops generating the pain signal. The question is not whether mirror therapy works in every patient. It does not. Systematic reviews, including a Cochrane analysis, have correctly pointed out that trials are small, heterogeneous, often unblinded, and vulnerable to placebo and attention effects. The question is not whether the evidence is clean. The question is why, in a non-trivial subset of cases, a visual illusion abolishes a pain that opioids and neuromodulators cannot touch. For this to work at all, several cognitive faculties must be simultaneously intact and cooperating. Visual processing in the occipital cortex, body schema representation in the parietal lobe, particularly in the right inferior parietal lobule, motor intention in premotor and supplementary motor areas. Ownership, the sense that the reflected limb is mine, generated in temporoparietal junction circuits. And somewhere in this distributed choreography, a signal being generated in the deafferential somatosensory cortex quiets down because the brain has been shown, through the eyes alone, that its model of the body can be revised. This is the anomaly. Not that a mirror helps, that a mirror sometimes completely extinguishes a pain originating in tissue that does not exist, transmitted along pathways that cannot be rerouted, through a receptor system that pharmacology has tried and largely failed to silence. Mrs. Halverson does not have a neuroma problem that can be injected. She has a brain that has not yet accepted the amputation. And what I cannot explain, precisely, is how showing her a reflection teaches it to. What would it take to actually understand this? Several programs are trying. At the University of Gothenburg, Max Ortiz-Catalan's group has developed phantom motor execution, a protocol that uses surface electromyography from the residual limb, machine learning to decode intended movement, and a virtual reality rendering of the missing hand that moves in real time with the patient's attempted motion. A multi-center trial published in The Lancet in 2016 reported sustained reductions in phantom pain in patients who had failed every prior treatment. At UC San Francisco, Prasad Shirvalkar's lab has been implanting chronic intracranial electrodes in the anterior cingulate and orbitofrontal cortices of patients with refractory chronic pain, including phantom pain, attempting to identify individual neural biomarkers of pain states and deliver closed-loop deep brain stimulation. The preliminary work appeared in Nature Neuroscience in 2023. Tamar Makin's group continues to map, in high-field MRI, how representation of the missing hand persists and changes over decades. These are serious programs, but they all share a limitation, and it is the limitation that interests me most. None of them can measure pain directly. They can measure nerve firing, blood oxygenation, electrical field potentials, patient-reported scores. They cannot measure the pain itself because pain is a subjective state, and subjective states are not currently instrumentable. This is the deeper problem phantom limb pain exposes. In medicine, we routinely measure 4 vital signs: pulse, blood pressure, respiratory rate, temperature. These are objective, external, reproducible. There is a 5th thing we care about more than any of these, and we cannot measure it at all: the patient's inner state, what they are experiencing, whether they are in agony or at peace. We ask and we record what they say on a scale from 0 to 10, and we treat that number as if it were a measurement. It is not. It is a report. Consciousness, the subjective field in which pain and every other experience arises, is the 5th vital, and we have no instrument for it. Phantom limb pain matters, beyond the suffering of amputees, because it is the cleanest clinical Demonstration that experience is not a passive readout of the tissue. The tissue is gone. The experience is not. Whatever the brain is doing when it generates the sensation of a crushed, burning, non-existent foot, it is doing something that our current monitors cannot see and our current pharmacology cannot reliably reach. Honest medicine, at the end of 2024, cannot tell Mrs. Halverson why her foot hurts. It can only offer her gabapentin, which may or may not help, and a mirror, which sometimes works for reasons we cannot fully articulate. Mrs. Halverson kept a photograph on her tray table. Her and her husband, both younger, on a pier in Duluth. She had mentioned in our first conversation that before the diabetes took the leg, she had been a ballroom dance instructor for 31 years. Her right foot, the one in the hazardous waste bin, had been her lead foot. She told me she could still feel it searching for the downbeat at night. On the advice of the rehabilitation team, we tried mirror therapy. A plain drugstore mirror, angled parasagittally on her overbed table. 20 minutes, twice a day. For the first week, nothing. In the second week, she reported the crushing sensation in her absent toes had loosened. By the fourth week, her pain score was 4. Not 1. Not 0. 4. She still took pregabalin. She still had bad nights, but the foot, she said, had stopped screaming. I do not know why it worked, in her, to the degree it did. I do not know why it does not work in every patient I offer it to. I do not know whether the relief came from cortical reintegration, from expectation, from the simple ritual of attention, or from some combination that the current literature is not yet equipped to name. I know only that she slept through the night for the first time in 2 months, and that when I asked her what she thought had happened, she said she thought her brain had finally seen the leg was gone. That may be the best explanation we have. It is not enough.